We are working on the website. Catherine's been doing a great job on working on the website. So fairly soon, I think it's up and running live. Is that right, Catherine?
Yes, that is correct.
And it is at what is the web address?
IHCCA.org.
Okay.
And if you would like to subscribe to our news and events, go to that website. In the menu, there's a subscribe button.
Okay, perfect. And then in the chat, there's also some information on our sponsorships. And then also if you have any updates or anything that you need to tell us, then just go to admin@ihcca.org and Catherine will answer your questions, which I'm so thankful for. IHCCA does not have a membership. It is ran mostly by sponsorships, and there's a bunch of different packages that you can be a sponsor for depending on your budget. So if you have any questions or need more information, Mary Malott is taking that over for us. Thank you, Mary. Do you have anything you want to add to that?
Sorry, I'm trying to find my mute button.
I know.
I'm muting myself. No, but there are various opportunities and packages for sponsorship. So please reach out if you're interested, and I'd be more than happy to share details and information with you. And we certainly welcome you to be sponsors.
Thanks, Mary. And speaking of sponsors, I want to thank Melina for being a sponsor for this session, and for Norco, and also for Terrace Home Health for being sponsors. So thank you. The vision of IHCCA, and in particular Project HELP, is to provide current and upper level education that pertains to Idaho. And we also have a very strong policy and legislative committee. If anybody wants to be on a committee, just let us know. We will be having or starting a conference committee, I believe, in the very near future. Jane Josephson from BSU said she'd be happy to kind of work with us on that. And then Amy Legat will also be part of that. So we'll be, hopefully, I don't know if it'll be this year, but in the very near future, we'll have another conference, and I'm hoping it'll be in person. I don't know if you were able to attend the first two that we had, but they were amazing. I think they were really rich in information and resources. There is big changes coming regarding the Idaho Post and advanced care directives. Please sign up for updates, as we'll be posting that as they happen. And our meeting on, I'm just looking here really quick, August 5th, we'll be doing a lot of what is happening with the changes with the Post, the Idaho Post, and with advanced care directives. And so just make sure you put that on your calendar, same time, same place, just August 5th. And next month we have, or not next month, but the next Project HELP on June 3rd will be Mary McGoldrick. And she's on the advisory board for both the Joint Commission and for CHAPS for infectious prevention and controls for home health programs. She's very up to date on what's required for PPE, and she also does a lot of consulting for survey. She said that a lot of the surveys are, even though people have PPE, they're not staying within the guidelines of the CMS, and so they're getting flagged on that. So I think it would be a very good and very current update on the requirements for PPE in the homes. With that, I think we have gotten through all of the homework or all of the housekeeping stuff. So again, we are being recorded, and I'd like to just welcome our speaker, Kirk Cheney. Did I say that right?
You did. Good job.
Okay, I'm really bad with names. He's a general counsel for the Pennant Group. He's also the general counsel for a technology company in Boise, and he earned his law degree in Yale Law School. So with that, Kirk, take it away.
Thank you. Yeah, I'm like Kim said, thank you, Kimberly. I'm Kirk Cheney. I'm the general counsel now for the Pennant Group. I was the general counsel before for a technology company before this job. And the Pennant Group is our subsidiaries operate home health and hospice agencies in 14 Western states, and then the other half of the business is assisted living and independent living buildings in some of those same states. And so that's where my expertise is, and that kind of informs the way that my presentation might look. I know a lot of healthcare presentations are focused on hospitals, but when I'm reading there, when you read these rules, there's thousands of pages, and I tend to hone in on the ones that apply to the business that I'm in. So I have more of a home health and hospice angle in particular. And maybe I'm not so as expert on some of the hospital rules or even SNF, but that's where all these laws apply to each of those care settings. And I apologize for my video quality. Like many of you, I'm on 15 Zoom calls a day, and the one where I'm supposed to be the presenter is where my webcam won't work. So I queued up my phone. Hopefully you can still see me okay, just with a low angle and bad light. I'm going to talk about the fraud and abuse laws, in particular the anti-kickback statute and Stark. But the the False Claims Act is kind of part of that same bundle. I know that's not the main topic, but I just want to touch on it a little because it's one of the main fraud and abuse laws, and it also overlaps a lot with the other two. So if you'll journey back with me to 1863, we're in the middle of the Civil War, and these unscrupulous shysters start selling mules to the government, claiming that they're thoroughbred horses, or ships that are rotten wood with paint over it, pretending to be good naval vessels, or barrels of hay or flour supposed to be gunpowder. And the Union Army and Abraham Lincoln didn't like this and passed a law called the False Claims Act. That's William Tecumseh Sherman. I'm sure he didn't have anything to do with the law, but anyway, passed something called the False Claims Act to make it unlawful to defraud the government, basically, just to use a false claim or a false representation when you're doing business with the government. And so the basics of that law are that it's unlawful to knowingly submit a false claim to the government for payment or approval, or use a false record or statement in connection with one of those claims. Or if you figured out you've got more money than you're supposed to keep that for more than 60 days after you discover that. So that's the basics of the False Claims Act. And it has serious penalties, which are civil and criminal. You have to give back 3 times the amount of the claims, plus a penalty on top of that per claim, which can add up very quickly. Plus you can be excluded from Medicare and Medicaid, which for most folks, especially in home health or hospice, where there's not very much private pay, would basically ruin your ability to operate. And you can have criminal penalties of up to 10 years in prison. So it's a big deal. And many people will say, but of course, I'm not one of those unscrupulous people. My company would never intentionally defraud the government, because the word knowingly was in there. But unfortunately, knowingly in the False Claims Act is a broad term, which is interpreted to mean actual knowledge, which is the way we commonly think of knowingly, but also deliberate ignorance of the truth or falsity of the information, or reckless disregard. So if you just bury your head in the sand and try not to learn about the fraud that's happening in your operation, or try not to ask too many questions about the billing issues, or just ignore them, that's also considered knowingly in the sense of the False Claims Act. So it doesn't work to just hide from the truth. Does anyone know who that is in the top corner there? Anyone listen to lots of music in the 90s? It's Alanis Morissette, and it's random, but she dated Uncle Joey, so I put him on here too. But she had her breakout song was "You Ought to Know." I don't know if anyone remembers that, but that's, I think of the Alanis Morissette standard with the False Claims Act. If you ought to know that these claims are false because you're not doing anything to make sure that the billing is correct, and you're ignoring the falsity of the records, then that's good enough for the government. Good enough for the government to want to take it back and do something about it. So these are some examples of false claims. Charging or submitting claims that were not rendered, that's pretty obvious. That feels like fraud to most people. Submitting claims for services that were not medically necessary, for which the patients don't meet the medical criteria, double billing. I'm not going to read every one, but obviously forging signatures, failing to report an overpayment. But the one that sticks out here, because we're talking about Stark and anti-kickback laws, is that if you pay a kickback to a physician or a referral source in violation of Stark or the anti-kickback law, it's automatically a false claim. So you fall into all those other penalties that I said before, in addition to the penalties under the anti-kickback statute or the False Claims Act. So that's why I said there's a lot of overlap. And that's how the government and the DOJ bring so many cases for kickbacks and Stark violations. Stark isn't primarily criminal, but these other ones, the anti-kickback overlaps a lot with false claims. This is a picture. I don't know if we have any hunters in the audience. I just searched for a picture of a person with a lot of animals, because this is how I think of the government enforcement agencies on this. And these are healthcare companies. Every year they publish on their website a press release of how much money they've gotten back and how many cases they've brought from healthcare companies. The latest one came out a couple months ago. They recovered 2.2 billion in False Claims Act cases in last year, and that was even during COVID when things were a little bit less aggressive. And if you see that graph in the top right corner, most of that was healthcare. There's other kinds of companies that deal with, that could be brought into these cases, like government contractors and defense firms, but most of it is healthcare. 1.8 billion out of that 2.2 was healthcare. So let's talk about the anti-kickback statute. This one is, I think people don't realize how broad it is and how little wiggle room there is in the language. I didn't put the exact language on here, but in layman's terms, you cannot give or get or offer or solicit anything of value to induce referrals of Medicare or Medicaid business. That's the basic. On its face, that's what it says. And when the OIG writes advisory opinions about when people, you can ask questions and say, hey, we're thinking about doing this thing. Is that okay? Usually they say no. Usually they say, well, are you giving value? And are you getting referrals? And is one purpose to induce a referral? Then no, it's not okay. Or could it be construed as such? And anything of value, obviously people think if you hand sacks of cash or briefcases full of cash to a hospital and say, thanks for the referrals, that is obviously a kickback. But obviously most of the forms that it takes are much less obvious and much less direct. So obviously money, but items, perks, services, rental space, staff, waiver of copays or deductibles, over or under payments. All of these things are possible value. Remuneration is the term that they use in the statute. So all of those are remuneration that you're giving potentially in exchange for referrals. And there are a bunch of safe harbors, which we'll get into, in which most of the new changes relate to. So most of the things that seem like a kickback on their face that lots of people are doing are probably within one of those safe harbors. But those are very particular and you have to meet all the criteria to satisfy them. So this is the basics. You can't give or get or even ask for, even if you ask but don't get it, or if you offer but don't get it, something of value in exchange for referrals. That's a violation. So here's some recent examples that I just pulled off the DOJ website. In the top right one, there was a guy in Virginia who just found out a lot of elderly people's phone numbers and made a call center and started cold calling them and asking them if they'd be interested in home health services. And if they said yes, he sold those people's information to home health agencies in the right geographic area, so that they could sign them up for home health. So he offered inducements, they didn't say what, to the potential patients to sign up. So he said, hey, you'd be great for home health, and if you sign up today, I'll give you whatever, a free toaster. I don't know what he offered. And then sourced those out and got payments from the home health agencies for those. So he went to jail for 60 months. And we'll get to the safe harbors. You can have your own marketer that's employed by you out there looking for leads. Obviously, that's their job. But that's because there's a safe harbor for employees. But you can't have a third-party contractor that you're paying on a referral basis. So the other example here is speaker fees, so-called speaker fees for doctors. Novartis, a big drug company, for years paid doctors to come to give speeches at fancy restaurants with top shelf liquor and, hotels and whatever. Sometimes they didn't even come and they still got paid. Sometimes they gave a 2-minute talk and, got paid for 3 days of entertainment. So the kickback there is that they were obviously being treated to perks in exchange for writing prescriptions for this drug, and Novartis was billing Medicare or Medicaid for those, and so it violated the anti-kickback statute. Another one here is a EHR vendor. They just had to pay just this year $18.25 million for kickback violations. A similar thing, they invited prospective customers to concierge events with free tickets to sports events, entertainment, recreational events, and so forth. So same type of thing. And then those providers who would buy that EHR would get subsidies and reimbursements from the government if they used it. So that's how it got tied into government payments. Stark is kind of similar, but it has more to do with physicians specifically. And so it applies more in the hospital context than in some of the post-acute settings. But if a physician or their immediate family member has a financial relationship with an entity, then that physician can't refer patients to that entity for designated health services and can't bill Medicare for those services. So this law was put in place to prevent physicians from owning a bunch of businesses, being a primary physician for someone, and then referring all that business to their own entities so that they could get a bunch of money at each step of the way, their own lab, their own ambulatory service center, etc. Designated services include most medical services, hospital services, lab supplies, therapy. So if they owned a DME company and they, prescribed their own DME all the time, that would, or if they ordered it, that would be another example. This one is a civil statute, so intent isn't relevant, or it's not required like it is for the anti-kickback statute. It just, if you violate the face of the statute and you refer designated health services to an entity that you have a financial relationship with, then you violated it. The penalties here are up to $15,000 per service that was referred, 3 times that in fines, and a refund of improper payments. Another way that the Stark Law is often called the physician self-referral law, which I think is helpfully descriptive because it kind of tells you what the law is about. Finally, the one more is kind of like the same thing as those two, but for patients. So you're not paying referral sources or giving them free stuff. You're giving it directly to patients in order to sign up. And so, you know, like I said, I was a technology general counsel before I came into the healthcare space. And this is so normal in every other business, right? Like, hey, sign up today and you'll get something great, or refer a friend and you'll get something great. You'll get $200 or you'll get a free whatever. But here we're dealing with taxpayer money, government money, and they don't want, and also more vulnerable populations in you know, often particularly, well, both government programs have vulnerable populations. And so they don't want those people to be deciding based on, you know, the free stuff you're giving them. They want patients to have choice that's based on quality of care and sound medical judgment and so forth, and not just on perks. So you can't give things of value to Medicare or Medicaid beneficiaries if one purpose is to induce them to use your services. There's an exception for nominal value of no more than $15 per item, or $75 in the aggregate on an annual basis per beneficiary, but it can't be conditioned on the use of your services. So you can give, you know, keychains or magnets or whatever, but or small, you get it, small stuff, but those are the dollar limits. And even when you're giving those things, it can't be like a direct, hey, we'll give you this if you sign up. It's just, we went to a health fair and we gave out squishy balls, and that's okay. So all of this ties into patient freedom of choice, which is often talked about. And I hadn't even like gone and looked at the exact language of where that comes from. And this is Social Security Act and Medicare, Medicaid provisions. It says that a patient may obtain services from any qualified Medicaid provider that undertakes to provide services to them, and similar for each program. That's the basic thing. The patient gets to choose who they want to use, and patient steering is often the term for making them go one way or another in an improper way. And because this language is kind of it's not totally prescriptive, it doesn't say exactly what that means. I think there is some squishiness and fuzziness in some people's minds about where those boundaries are, even for me, frankly. And you know, it's something you'll want to talk to your own counsel about if you have questions about exactly what that means. One thing that does inform it is the discharge planning rules, which were revised in 2019 for hospitals, but it also applies to home health agencies. And then SNFs have their own that are kind of similar, skilled nursing. Basically now they strengthen these rules so that hospitals have to inform patients that they have freedom to choose their own providers, and they have to respect patients' preferences. And when they're making a discharge plan, they have to share a list of appropriate local post-acute providers, and it has to include everybody in the local area, except that home health agencies have to ask to be on it. So if you have a hospital referral source potential that you want to let them know you're out there and that you have good quality and we'd love to be on your list, you should reach out and do that. It must include quality data so that the patients have something to go by, and not just, you know, whoever the hospital likes or whoever they're friends with. And the list can't be qualified or limited. So they can't like put one of them in bold and 65-point font, and then, you know, the rest of them cut off or not on there. So that's pretty new. That just happened at the end of 2019, those rules. And I know many of you might, if you're in home health, might know that you're now supposed to include similar, information, quality information when you're discharging from home health for other providers if they're switching providers. So that's the basics of patient freedom of choice.
Can I ask one quick question on that?
Yes.
Okay, so if you go, would you go back one slide, please? So
Yeah.
in the first bullet point, it says a Medicare or Medicaid patient may obtain services from any qualified Medicaid provider. I'm just curious why it only says Medicaid and not
That's-
Medicare or Medicaid.
Yeah, that's just because I didn't want to clutter up the slide, but those two citations there, it's like the same for either one. That I just took the Medicaid language, but it's the same.
Okay, thank you.
You're welcome. So the anti-kickback statute has these safe harbors, which is kind of where we're going to get to, because a lot of the new changes have to do with these safe harbors. And I said these are the classic ones because they've been around a while. A lot of the safe harbors are super particular to certain kinds of providers, and they're kind of arcane and funky, and not many people use them. And they would basically require you to, if they apply to you, you'd know it, and you'd have to have your lawyers help you through it. These are the ones that are kind of general that a lot of different types of providers can use. Or just I put them on here because there's not time to talk about every single one, and these are some of the main ones. So an employment relationship is the one I mentioned before. You can pay your own employee to generate referrals for you. If you have a marketer, that's exactly what they do. You can pay them based on their productivity, and they have to be a real bona fide employee and not a contractor. So they need to be W-2'd and employed, and you have to have direction and control over their work, which is one of the tests for an employee. There's sub points in there, but that's the basics. So that's the employment relationship or employee safe harbor. Space or equipment rentals. So if you're renting space from a referral source or a potential referral source or equipment, sometimes you could try to structure a kickback by saying, hey, rent this room from us that you have no need for and pay us a lot of money, and we'll call it a rental, but really you're just trying to pay us to make us happy, so we'll send you patients. So there's a safe harbor, but it has to be in writing. It has to be at least a year. You have to have a legitimate use for the building, for the space, and it has to be fair market value. Fair market value is one of the key principles that underlies all of these safe harbors. If you're really paying for something and you're paying a fair price for it, and it's not about referrals, you're often going to be able to find a safe harbor. But if you're paying more than you should, or less, or whatever, and something seems off, it might be because you're secretly doing it for referrals. So personal services arrangements are the same. If you're paying for a service and you're paying fair market value for it, and you're not just paying for Medicare or Medicaid business, then there's a safe harbor for that. There's others. But the key themes, like I said, are that you're paying fair market value and you're not taking into account the volume or value of referrals. Stark has exceptions. They're not called safe harbors, but it's kind of the same concept. They are not a violation of that statute. Similar ones, the first three, there are physician incentive. You can pay doctors on productivity, and there's group practice rules. A lot of, like I said, if I worked for a hospital, I'd probably know those backwards and forwards, but I don't, because we don't pay physicians, except that we have medical directors for our agencies, and we have a carefully drafted medical director agreement that meets the safe harbor. But as far as the more complicated physician payment rules, there are safe harbors for those too. Fair market value payments, which is kind of a catch-all that encompasses some of these same concepts. And then this one is unique to Stark in a similar way with the beneficiary inducement statute, where you could give a certain amount of stuff to a patient per year. You can give non-monetary, so items or services, compensation up to $429 annually per physician. So you need to track that. You need to be careful not to do more than that. That could be things like meals or like education types of programs, items, services up to 429. That's updated every year, and that's the latest number for 2021. But that can't be for referrals. That would be, incidental things that arise in the, as a nature of working together in a relationship. It's also very relevant for hospitals because the doctors are there all the time. And so that can add up over the year. And they have to keep track of how much they've done per physician. So here's a pop quiz. And I am planning to leave about some time at the end for general Q&A after I get to the changes. So I just wanted to do a pop quiz on the basics or the standard rules around this, and then I'll talk about what's new. A hospice has several patients at a skilled nursing facility. Their bingo machine breaks. The skilled nursing facility's activities director says, "Be a good partner and buy us a new one." Is that okay? The folks I can see are shaking their head no. These are real examples. This is a real example that we had. Oops, it skipped around weird. Anyway, I'll come back to that top one. Obviously the motivation, why would a hospice just buy a bingo machine for no reason for a SNF? It's obviously because the SNF has potentially a lot of patients. Obviously our hospice said, no, we can't do that. And, it's tough because sometimes they say, well, so-and-so down the street will. And, it's kind of like trying to go the speed limit when everyone's going 40 over, but you can't do it because it's a kickback. The motivation to buy a bingo machine for a skilled nursing facility is to get more referrals. I'll go to the top one. An assisted living facility has a preferred provider relationship with one home health agency, and all residents are encouraged to use that home health agency. Is that okay? Well, that one is trickier. It depends. So an ALF is not under those, is not listed in those discharge planning rules that apply to SNFs and home health and hospitals. There's no rule that says they have to give a list to everyone, all the residents. And you are allowed to have preferred providers in all of these places, but you have to still respect patient choice. So you can have, especially with the new rules that I'm about to share, where you can enter into value-based enterprises with providers across the continuum. You can be in a sort of partnership relationship, preferred provider relationship, but in those other settings, even if you are, you still have to say, here's all of them, choose one. And you could say we work with this one a lot, we like them, but you can't override patient choice. And in an ALF, you can't get paid for this, especially. So if the ALF has a preferred provider relationship with the home health agency and they're getting paid per referral, or in some other way getting remuneration back for that, then it's definitely violating the anti-kickback statute. And someone asked me about this and how is this okay? And I don't understand all the details of how it's happening, but it's definitely not if they're getting paid for the referrals. The ALF might think, and this sometimes happens because a lot of them, some bill Medicaid, but others are totally private pay. So number one, they may just not know about these laws. And number two, they may think they don't apply because they get private pay. They're not charging the government for the assisted living occupancy. And so they think that they have nothing to do with Medicare, Medicaid, but they don't realize that they're referring that person to Medicare, Medicaid businesses. If you're referring to a home health agency, they're almost definitely going to bill Medicaid or Medicare. And so it could be just ignorance on the part of the assisted living director. Or maybe they're not getting paid for that and they just really like that provider. And then maybe it wouldn't be a kickback, but it's definitely close depending on the facts. This one, I already kind of spoiled this one, but your referral source has a vacant room. They ask you to rent it for a generous monthly rate, although you really have no use for it. Excuse me. That is probably not going to work because you have no use for it. If you did, and you met the specific space rental safe harbor, which you have a written contract for at least 1 year and you have a legitimate business purpose and you pay a fair market value rate, then you can do it. But if the top part is true that you have no use and it's just a sham to pay them money, then it's not going to work. A SNF expects a home health agency to provide free CNA staffing to supplement SNF staff. Is that okay? That's very common, and something that different providers in our different markets have basically insisted or asked that, everyone do, and we just can't do it. You can obviously, if you have a home health or hospice patient in that facility, you send your staff in to meet the care needs under the care plan for that patient or those patients. But you can't just provide general staffing that stays there around the clock to supplement their staff, because what you're basically doing is subsidizing their staff with free employees to be a good partner or to get more referrals. And I hope that people are coming to learn that that's not okay. And that there have been cases brought on this basis, usually in combination with other things, but you're not supposed to be providing free staff to referral sources. Now there's the new safe harbor, which I'll talk about, allows you to do this sort of. They have to pay 15% of the staff that you're providing. So I'll talk about that in a second.
And it looks like there's a question in the chat.
Okay.
So this was to the previous question,
Okay.
or previous comment. So what if the residents are being told they have to use a certain home health and are not being given a choice? Also, the home health and the assisted living facility are in business together. Is this okay?
No, it's definitely not okay if they're being told they have to. Like I said, they should, that would violate the patient choice provision of that I mentioned before, that they are entitled to use any qualified provider. So that part's not okay. Obviously, it comes down to the way that's being presented to them. If the home health and the assisted living are in business together, that also has, I guess I need to know more about what that means. And if the assisted living business is getting remuneration from the home health referrals or not. But if they're, I don't know, if they're joined by the same or owned by the same company, presumably the value would accrue to both entities. So it's definitely a tough one. I guess I don't know enough about the specific details, but it would raise red flags for me. And I would not allow, if I were advising one of our home health agencies about that, or the assisted living, I would definitely say, you can't say you have to use this, you have to, this specific agency, that's not okay. You have to advise about their choices and let them choose.
So Kirk, also, there was a comment also that the Bureau of Facility Standards states that if it's on their admission agreements, is that okay or not okay?
If what's on their admission agreements?
That they have to use a certain home health or agency.
I guess I would think still no. I don't think you can contract around federal statutes that say you have to do X. I mean, you have to provide patient choice. So I guess I'm not familiar with that enough to say. I'd have to look into it, but my instinct is that that's you have this federal standard that says if you want to be paid by Medicare or Medicaid, you have to allow the patient to choose their provider. And I guess you could argue that agreement is them choosing, a specific home health at the same time, but I don't know. I haven't looked closely enough at that to say for sure, but that still gives me pause. In general, if I were advising on that with our business, I would say that's pushing it, and we should let them choose. Thanks for the question. Sorry if I can't give you really perfect answers on some of it without knowing all the facts, but those are great questions.
Thanks for even attempting to answer those ones.
Yeah. So what has changed? I know I have only 15 minutes left and I want to give time for more questions. So there's 2,000 pages of changes, and I tried to take the stuff that's the most relevant. It's amazing how, and a lot of that is like back and forth about why they changed the rules the way they did. That's not all specifically rules, but the final rule has a lot of dialogue and discussion about it. So there's 6 new safe harbors, and then flexibility added to 5 of the existing ones. All the changes from a provider's perspective are good. I mean, they're all helpful. None of them are worse than they used to be. They all got a little bit broader, so that's great. But they're all also mostly kind of complicated, and so I had mixed feelings about it. I felt like, okay, this is good that it's all going in the right direction for providers, but it's also not simple to comply with some of them. So these are the 6, and I'll go into the ones that are most important, I think. And those are these 3 that are bracketed together here, which created this kind of new concept for these preferred provider relationships. And I just saw a news article this morning about 2 big companies that had entered into one of these. So these are the core concepts. You basically create something called a value-based enterprise. And you create that with 2 or more entities, which can be providers or payers or a combination of those. And they collaborate to achieve a value-based purpose for a target patient population. So you identify a target patient population based on valid, verifiable criteria, such as high risk for readmission or something like that. And then you define the value-based purpose and what you're trying to measure and achieve for them. And then you get to unlock additional safe harbors and flexibilities. To do it, you have to have a contract, you have to have an oversight body, you have to monitor it regularly, at least annually. So it's not simple, but it's not like setting up a whole new company. They're pretty flexible about how you do it, but you probably would have to get lawyers involved to set this up. And so the definition of these different concepts, value-based purpose is pretty broad: coordinating and managing care, improving care, reducing costs, transitioning to value-based payment models. So all these new things are supposed to be responding to the complaint among providers that it's really hard for us. You want us to, reduce costs or improve care and just stop, just billing for services. But then you have all these rules that make it really hard to collaborate with other companies, because HIPAA and a kickback statute and everything we do between companies is super complicated. We might trip up and go to jail, so we don't do it. And that's the purpose of these. I'd say they got a little bit there, but not all the way, because it's still kind of scary. Anyway, that's a bit of a digression, but the target patient population is also flexible. A set of patients identified in advance with legitimate and verifiable criteria to further the value-based purpose. So you basically pick something you want to target, someone you want to do it with, define it in a contract, and off you go. They excluded some types of companies that you can see at the bottom because they felt like it would be too fraught with potential fraud or, driving unnecessary services, medically unnecessary services. So they won't let those companies participate. So why go to the trouble? Well, care coordination, if you can create one of these, you can create a pretty powerful cross continuum partnership that everybody wins, because you can work more easily with this company. You're naturally probably going to do a lot of business together, and you will benefit the patient population. So, and probably drive down costs. So like I said, everybody can win if you did this right. You can exchange in-kind remuneration, so staff, software, services. One of the examples that CMS gives is that a skilled nursing facility could provide care coordinator staff to a hospital, and that, you know, they can manage the population health together of this target patient population, and it could be a really strong partnership. The recipient, so in the hospital in that example, would have to pay 15% of the cost or the fair market value of that item or person or service. You can't use that for marketing or patient recruitment, though, which means you can't trumpet it as a reason to become a patient in the first place. And the staff person can't be a marketer that you send into the hospital to go around drumming up business for the SNF, or same example for a home health and a SNF. If you send a home health care coordinator to work at a SNF and the SNF paid 15%, they can't be going around the SNF recruiting patients. And it must support the value-based purpose, and it has to be monitored for success. There's some details about what that means. But, you know, if you're thinking about doing it, you probably have to talk to an attorney, unfortunately, to get down into the weeds of setting those up and what your measurement criteria will be, because it's very new, and we've been trying to work through it, and it's not totally clear, and there haven't been that many examples yet. But that's the basic concept. If you take financial risk together, so if a payer and a provider go in together and agree to manage this target patient population, and that both parties will share some of the risk if they get it wrong and if they lose money, based on a capitated payment. These are pretty complicated. I don't think, you know, these are bigger companies setting these up at the kind of corporate level with a lot of finance and legal involved. So I'm not going to go too far into those, but if you're willing to take risk of losing money, you can have even broader flexibilities for this care coordination. And so last of all, if you set up a VBE and meet this safe harbor, then you can also get some flexibility on the patient inducement stuff, like giving stuff to patients. You can provide up to $500 of items, tools and supports, it calls it, per target patient per year to support the value-based purpose. That can be very broad. It can include health technology, nutritious food, transportation vouchers, home supports, a lot of things that would be potentially problematic if you provided outside of this framework, because it would look like you were offering stuff to patients to get their business. It has to be recommended by their licensed healthcare professional, and it can't be used for marketing or patient recruitment. So that was a lot, I know. And it's a big, like I said, there's a lot of details there, but that's the biggest change. That's what all the hubbub's about, I guess, for the changes of and a kickback statute and Stark. CMS and OIG are trying to say, hey, we're trying to help you work together with other providers and with payers. We're trying to break down some barriers. Unfortunately, they did do it in a pretty complex way, as you can see, though. So that's what it is. I hope that's helpful. I wanted to talk before I turn it over for questions, just about local transportation, because this one gets people too. There was already a local transportation safe harbor, but they made it a little bit more flexible, which is appreciated by providers. If you're marketing this as a way to get business, you aren't in the safe harbor, the old one or the new one. You can't use it as a recruiting tool for patients, but it now allows you to have a little bit more mileage. So generally 25 miles, or in rural places, 75 miles. These are all the other conditions that apply. You have to have a written policy. It can only be for existing patients. You can't send them in like limousines or first class jets. You can't advertise it, or you can't advertise to them while they're riding in the car. And then there's a even broader one with no mileage limit if you're transferring them from an inpatient facility to a residence, theirs or one they choose, after they've been on observation status for 24 hours. So that was a lot. I hope that was good. Let's take questions.
There was a question in the chat from Brandy, if it's not okay, and I think we're going back to referring within a facility using their own home health and hospice or services. If it's not okay, who do we report it to and how do we make a complaint?
Yeah, that's a good question. Who do you report it to? I mean, you can report it to, well, I actually don't even know. You could report it to the local health department, but I don't think that's not really their purview. I mean, to start a criminal type of investigation, you would report it to CMS, I think, and they would report it to the local, the DOJ or the U.S. attorney in that area.
One of the questions was, would it be the state Secretary of State or the OIG?
I think it would be the OIG.
Okay.
The Secretary of State really has more to do with, creating entities at the state level and stuff. But OIG would be, I mean, that's who would enforce it. So that's who you would report it to. I just don't know where the portal is or anything for that because we've never tried to do it. But that's the right party that it would eventually bubble up to. So I think that's where you would go. I just don't know the exact mechanism of how you do it.
Okay.
This is Catherine. I believe you can start a complaint process or get more information on the OIG website.
Yeah, I think that's right.
Also, Kirk, if I could, this is Steve Millward. I'm with the Department of Health and Welfare. And some of these issues have to do with the licensure or certification of the facility. So in the instance of a residential care assisted living facility, it's a resident's right that they can control their own healthcare related services. So that report would be made to licensing and certification with the Department of Health and Welfare.
Yeah, great. Thank you for time. I appreciate that.
Thanks,
I
Steve.
figured it would certainly be, I figured it would certainly be relevant, but the prosecution would end up with the OIG, but that's definitely, there's lots of parties that would be interested to know this, I guess. Great, thank you.
And then also, I think the question becomes, how does the resident know that they have that right?
That's
right, to participate in their, in their own choice if they don't know to ask, right?
Right. And that's why the SNF and hospital rules were revised to require you to put that in their discharge plan. It's just that assisted living isn't regulated by CMS. And so there's not a similar rule for assisted living, but I think it's a good thing. I'm glad they added that rule because you're right. If they don't know that they're supposed to have a choice, then they might think they won't know, like you said.
I raised my hand for questions, so I'll just throw mine out. On the local transportation, I'm finding this to be more of a conversation on an ongoing basis because the safe harbor, as you applied, says allows for free when the patient is yours for an existing patient. The thing that we're fighting or seeing more of is the patient is not necessarily like for a home health or a SNF, not a home health, probably more likely a hospice or a SNF or an ALF. Sometimes it's not their patient yet. The patient is leaving the hospital and it really won't be the hospice's patient or the SNF's patient until the patient actually resides at the next location. Do you think that's a legitimate loophole? Because we're seeing hospital discharge planners pretty regularly now just saying you will line up the transportation. And I've had the argument, it's not my patient. It will be, but it's not yet. And do you have any thoughts on that?
I don't, because we've taken the same position and had the same argument you have, which is that it's not our patient yet and we can't rely on it. We can't rely on the safe harbor when it's not our patient. So we have not agreed, to my knowledge, to do that. And so I agree with you. It's for existing patients, which kind of takes away some of the usefulness of it, except for the hospital where they've already been there and they're offering to send them home. That's an obvious good use for it. But when it looks like you're offering it to get them to be your patient, it's problematic. And so I don't have a good answer for you.
Can I bounce another thought off of you?
Yes.
It is common practice, and it has been common practice for a really long time. And I think the thought is we know that it's gonna be our patient or the SNF's patient. So I kind of held my ground for a long time saying, I'm not gonna do this. And then it became, well, I probably need to do this because every SNF in the Valley is doing it. Every hospice company in the Valley is doing it. And if I don't participate and help with transportation, then I just am not an easy company to work with any longer. And so I feel like it's that whole ostrich in the head thing, like, well, am I participating in this knowingly when I know this isn't my patient yet? But SNFs have been doing it for a decade.
That's one of the frustrating things with these laws that I was kind of trying to allude to in the beginning, is that it's really broadly written. And when you directly ask OIG to say that they don't mean what they said, they never will. They'll always say, all the letters, advisory letters say, nope, you can't do it. We mean what we say. But then the prosecutions that they bring are for more flagrant violations, like patently false submissions of claims or millions of dollars of speaker fees. And a lot of these smaller things that it seems like a lot of people are doing don't get enforced against. And so it can feel very difficult to try to be being above board when all your competitors aren't. That's something that we also deal with and have to talk to our administrators about all the time. I tell them that in the long run, doing it right will benefit you, and you have to win on the quality of your care and not on the corners that you cut. But it's I'm sympathetic to the fact that it feels like you're playing in a game that's not fair. But I think in the long run, people get caught up with, and it's a choice you have to make.
Thank you.
You're welcome. That's a really realistic, good perspective. Thank you. Well, I know we're over time. I'm sorry. I thought I'd leave more time. I guess that's what presenters always do, but I hope that you got value from it.
Kirk, I really appreciate you taking the time and everything. Everybody, it was recorded. It'll be on our YouTube page. Catherine, if you want to jump in a little bit, that's fine, because you kind of set it up. And it'll also be on the web page. So thank you very much, Kirk.
You're welcome.
I will send the YouTube and webpage information to everyone who registered.
Thank you. Yeah. Thanks, everybody. Have a great week. Happy April Fool's Day.
Thanks.
Thank you.
If I said anything wrong, it was an April Fool's.
That's perfect. You got it out. I love it.
Yeah.
Thanks, Steve.
Bye, guys.
Thank you.